In this video, we continue our discussion on drugs used in the treatment of peptic ulcer. Now, in the previous videos, we missed certain discussion points regarding the proton pump inhibitors. We did discuss that an acidic pH is required in the parietal cell for the activation of proton pump inhibitors. Now, the pH is maximally acidic in the parietal cells in the fasting state. So, the best time to administer these drugs would be around 30 minutes before meals, and ideally they should be administered 30 minutes before the first meal of the day, 30 minutes before breakfast. In general, these drugs are extremely safe, but on chronic use they can produce these sort of adverse effects. Again, these are extremely rare. Omeprazole is known to inhibit certain microsomal enzymes and is therefore prone for drug interactions. Right. Now, this is a diagram that we spent a lot of time on in the previous video. Just to add on this, the vagus nerve has an important role in orchestrating how hydrochloric acid is secreted by the parietal cell. By releasing acetylcholine, it stimulates ultimately the release of hydrochloric acid from the parietal cell. The vagus nerve also inhibits the D cell from secreting more somatostatin, and in this way it further increases the release of hydrochloric acid from the parietal cell. And this explains why there are surgical techniques like truncal vagotomy, highly selective vagotomy and so on, which are employed in the treatment of peptic ulcers, notably duodenal ulcers. Okay. So, in the previous video we spoke at length about proton pump inhibitors. In this particular video we shall speak about H2 receptor antagonists, prostaglandin analogues, antacids, bismuth compounds, sucralfate, and Helicobacter pylori eradication therapy, the cornerstone in the treatment of peptic ulcer disease. Now, H2 receptor antagonists act by competitive antagonism of histamine at the H2 receptors of the parietal cells. They are highly effective in suppression of nocturnal acid secretion. Especially evening doses of H2 receptor antagonists are particularly useful for this. Now, since suppression of nocturnal acid secretion enhances healing of duodenal ulcers, H2 receptor antagonists are best administered in the evening. Absorption may be enhanced by food, but these effects are unlikely to be important clinically. Therefore, when compared to a proton pump inhibitor is best administered on an empty stomach in the morning, 30 minutes before breakfast. On the other hand, a H2 receptor antagonist is probably best administered in the evening, irrespective of whether food is taken or not. These are some of the H2 receptor antagonists available in the market. Among these, cimetidine has got certain peculiar adverse effects. Notably, cimetidine inhibits microsomal enzymes and is therefore prone for various drug interactions. In addition to this, cimetidine can cause gynecomastia. Now, among the H2 receptor antagonists, the most popular by far has been ranitidine. But in recent times, ranitidine has come under scrutiny. There have been claims that a contaminant known as NDMA has been involved in the production of ranitidine. The investigation is ongoing and conclusions may be made once the evidence is out. H2 receptor antagonists may be less potent than proton pump inhibitors. However, they can still suppress acid secretion by around 70%. Alright. Now, let us move on to the prostaglandin analogues. We did discuss in the previous video that PGI2 receptors are located on the parietal cell, and upon stimulation they inhibit the parietal cell from secreting more hydrochloric acid. We also discussed that PGE2, the receptor for PGE2, is located on the mucosal epithelial cell, and upon stimulation it results in three events. Firstly, it causes increased secretion of mucus. Secondly, it causes increased release of bicarbonate, and thirdly, it causes increased mucosal blood flow. We discussed this. Now, at this point in time, it's important to understand that the receptor for PGI2 on the parietal cell and the receptor for PGE2 on the mucosal epithelial cell is actually one and the same. It is the EP3 receptor. The EP3 receptor may be stimulated by PGI2, PGE2, and among other prostaglandins, PGE1. What is the significance of this? Well, prostaglandin analogues were tried out in the treatment of peptic ulcer disease, and the prostaglandin analog that was specifically used for the treatment of peptic ulcer disease was a PGE1 analog. Alprostadil is a pharmacological preparation of PGE1, and structurally it is identical to endogenous prostaglandin E1. Alprostadil is useful in the treatment of erectile dysfunction when given intracavernosally. When given intravenously, it is useful for maintaining the patency of a ductus arteriosus. However, when used for peptic ulcer disease, it was found to be unsuccessful, and this was mainly due to a short duration of action, poor tolerability, and limited oral bioavailability. So the chemical structure of alprostadil was modified to produce another prostaglandin E1 analog. The result was misoprostol. Misoprostol was found to be more suitable for the treatment of peptic ulcer disease when compared to alprostadil in two respects. Firstly, it had a longer duration of action, and secondly, the oral potency was found to be better. Unfortunately, even misoprostol is rarely used in the treatment of peptic ulcer disease, and this is due to its adverse effects. Now, what are the adverse effects of misoprostol? Well, firstly, it's going to cause diarrhea. It will cause diarrhea in 30% of patients who receive misoprostol. Secondly, misoprostol can exacerbate inflammatory bowel disease. They can precipitate acute exacerbations of inflammatory bowel disease. And thirdly, and perhaps most importantly, misoprostol is absolutely contraindicated in pregnancy because it can increase uterine contractility. Now, of course, misoprostol can be indicated in pregnant females if we want to intentionally increase the force of contractions, like for example, if we wanted to conduct induction of labor, or if we wanted to perform a medical termination of pregnancy, or if we wanted to treat an incomplete abortion, or indeed if we wanted to prevent or treat postpartum hemorrhage. So misoprostol theoretically is the most selective drug for the treatment of a non-steroidal anti-inflammatory drug induced peptic ulcer. but unfortunately, due to its adverse effects, it is almost never used. The drug of choice for an NSAID induced peptic ulcer, or for any peptic ulcer for that matter, is always a proton pump inhibitor. Let us now move on to the antacids. The primary effect of antacids on the stomach is due to their partial neutralization of gastric hydrochloric acid and the inhibition of the proteolytic enzyme pepsin. Antacids work nearly instantaneously, and they are useful for rapid symptomatic relief. The antacids include the bicarbonates and the carbonates, as well as the hydroxides. In the first group, we have drugs such as sodium bicarbonate and calcium carbonate. Under the hydroxides, we have fixed dose combinations of aluminum hydroxide and magnesium hydroxide. Now, sodium bicarbonate is what we commonly call baking soda, and various combinations of these are available in the market. Most notably, a combination of sodium bicarbonate with aspirin. Now, sodium bicarbonate is an easily absorbable alkali. When absorbed into the systemic circulation, it can cause problems like, for example, metabolic alkalosis and sodium overload. This can be of serious consequences to patients with heart failure and renal failure. Calcium carbonate is an interesting drug to learn. Calcium carbonate may be used as an antacid. When given on an empty stomach, calcium carbonate would react with hydrochloric acid to form calcium chloride. And on an empty stomach, only 25% of calcium enters the systemic circulation, and this is good because our aim is to neutralize hydrochloric acid in the stomach. We have no interest in getting this calcium into the systemic circulation. When used as an antacid, calcium carbonate may be given 1 hour after meals, 3 hours after meals, and at bedtime. Nowadays, however, calcium carbonate is much more commonly used in the prevention of osteoporosis and the prevention of preeclampsia among pregnant women. And when used for these indications, we want maximum amount of calcium to enter the systemic circulation. To achieve this, calcium carbonate needs to be taken with meals, since food increases the absorption of calcium from the gut by around 25 to 30%. We now come to an important adverse effect of antacids, namely the milk alkali syndrome. Now, the medical management of peptic ulcer disease in the early 20th century was achieved mostly by the administration of antacids, and this was popularized by a famous physician named Sippy. The original recommendation of Sippy consisted of hourly administration of milk and cream together with Sippy powders, the main constituent of which was sodium bicarbonate. Subsequently, various variations of this regimen were employed, and each contained large quantities of milk and an absorbable alkali, usually sodium bicarbonate. Now, this came to be known as the Sippy's regime, or the milk alkali treatment, and very soon it became the standard of treatment for peptic ulcers. However, the milk alkali treatment had adverse effects, notably the milk alkali syndrome. Now, the milk alkali syndrome involves a history of excessive ingestion of calcium and an absorbable alkali. So, in the original milk alkali syndrome, the source of calcium would have been milk, and the absorbable alkali would have been sodium bicarbonate. So, history of excessive ingestion of calcium and absorbable alkali, together with findings of hypercalcemia, metabolic alkalosis, and renal failure. So, milk alkali syndrome can be quite a serious affair, and these days it is making a sort of comeback due to the overzealous prescription of calcium and vitamin D supplements. Next, we move on to the hydroxides. We have fixed dose combinations of magnesium hydroxide and aluminum hydroxide. Why do we use this in combination? Well, magnesium hydroxide is very fast acting, it is potent, but it can cause diarrhea. On the other hand, aluminum hydroxide is slower acting and less potent, but is constipating. So combining the two seems to make sense, and such combinations are freely available in the market. Antacids have no place in current and updated clinical guidelines for the management of peptic ulcer disease and related disorders. However, they do provide rapid relief of symptoms and are therefore very popular among patients. We now come to sucralfate. Sucralfate is sucrose octasulfate. It's sucrose octasulfate to which aluminum hydroxide has been added. Right. So how does it work? When administered orally, sucralfate enters the stomach where the pH is acidic, and in the presence of an acidic pH, sucralfate undergoes cross-linking. It forms a viscous polymer, and this coats the ulcer base. It forms a protective barrier and inhibits the hydrolysis of the mucosa by digestive enzymes like pepsin. In addition to this, sucralfate also stimulates local prostaglandin production. Obviously, since it is activated by acid, sucralfate should be taken on an empty stomach, preferably an hour before meals. Now coming to bismuth compounds. Now, bismuth preparations effective for the treatment of peptic ulcer include colloidal bismuth subcitrate and bismuth subsalicylate. Now, bismuth subsalicylate consists of trivalent bismuth and salicylate suspended in a mixture of magnesium aluminum silicate clay. The indications of bismuth subsalicylate include the peptic ulcer disease and diarrhea. In peptic ulcer disease, bismuth subsalicylate is useful because it binds to the ulcer base, it stimulates mucus and bicarbonate production, and crucially, it has got anti-inflammatory and antibacterial properties. Now, bismuth subsalicylate is also useful in the treatment of diarrhea because it has got an anti-secretory effect. It is useful for the relief of abdominal cramps and nausea, and it also has got an antidiarrheal effect due to the presence of the clay in bismuth subsalicylate. So, BSS or bismuth subsalicylate is indicated in peptic ulcer disease, in acute gastroenteritis, in the treatment and prophylaxis of travelers' diarrhea, and in other forms of episodic diarrhea. Right. Now, when bismuth subsalicylate enters the large intestine, a peculiar phenomenon occurs. The intestinal bacteria releases bacterial sulfides as a result of their ordinary life processes. The bacterial sulfides can react with bismuth subsalicylate to form bismuth sulfide, which can cause dark discoloration of the stools. Similarly, the sulfides in the mouth can bind to bismuth subsalicylate and cause a dark discoloration of the tongue. Now, a dark discoloration of the stools can be a confusing thing for the physician, because when a patient reports that the patient has got tarry stools or dark colored stools, the physician would normally first think that the peptic ulcer has started to bleed, and this is an important sign. This is what we call melena. Of course, if the patient has just been taking bismuth, then there is little reason to worry, because the darkish discoloration of the stool was due to bismuth and not due to a bleeding ulcer. So this could be a cause for diagnostic confusion. Right. Yeah. So, another peculiarity of bismuth subsalicylate is that in the presence of an acidic pH, it gives rise to salicylic acid, and therefore salicylism or acute salicylic poisoning is a possibility with bismuth subsalicylate. So these include the unwanted effects of bismuth containing compounds, dark discoloration of the tongue and the stools, salicylism, and something called Ray's syndrome, which we will discuss in greater detail when we have discussions on aspirin. Right, finally we come to the cornerstone of the treatment of peptic ulcer disease, namely Helicobacter pylori eradication therapy. It is the mainstay for the treatment of peptic ulcers. The greatest advantage of eradication therapy is the prevention of recurrence. Also, H. pylori has been classified as a carcinogen, and therefore treatment and eradication of H. pylori should always be considered in a patient with peptic ulcer. Now, there are multiple regimens for H. pylori eradication therapy. This is the bismuth quadruple therapy. There are other regimens like clarithromycin triple therapy and so on. Right. The major complications of an untreated peptic ulcer include upper gastrointestinal hemorrhage, gastric or duodenal perforation, a stricture at the ulcer site, gastric outlet obstruction, and of course the possibility of the development of a carcinoma. So this concludes our discussion on drugs used in peptic ulcer.